since there's a lot of questions being asked on what happens when there is a mismatch.
Especially if there are more abrasions coming from the cornea per se, how would you actually...
No, we have a session on afternoon on that.
Yeah, so there is a paper in GRS in the month of January, and Brad can comment more on that. So, and I can tell you the specific numbers because I was just reading it yesterday. So the authors found that if the mismatch between the axis of the refractive and the corneal cylinder is more than 20 degrees, then their results were inferior with the Contura system. If the difference was less than 20 degrees, then the results were very good. So and this is something, so this is something, a question for the surgeons now, that if in both cases we can do with using just the refractive axis cylinder, why do we need to worry about the corneal axis cylinder?
You're treating the refraction. As a refractive surgeon, you're treating the refraction.
No.
What was recommended studying the 10-year results now. I've already seen 20 patients at 10 years.
Okay.
And
anyway, we have a session of Contura on that same part. I think me and Dr. Gitanksha are going to show about.
So it is not any more new. So
and the second comment that I have is, if you look at us as a population, the Indian eyes, so we have smaller pupil size, okay? In the Western, we have slightly larger pupil sizes. So when you talk about correcting corneal aberrations, do we get the same amount of benefit that we get with what would be the case in Western eyes which have a larger pupil size? Because when you have a larger pupil size, there are more corneal aberrations that come into play for visual acuity compared to a smaller pupil size. So Indian eyes may just do better whether you do Contura or regular LASIK. That's something for the surgeons to answer in this case.
Just a comment on marketing, going back, I mean, especially in the Indian context, when you have 2 classes, people offer first or the second class. But when you have 3 classes, then they don't really want to go for the 3rd class. So when you are now offering microkeratome, femtolasic and smile, nobody wants to go for microkeratome. What I found is that way femto and smile have been complementary to my practice at least. In the sense, almost 90% of the patients are opting for either of these two, and the number of microkeratome numbers have really gone down. And as regards your comment, I think the cutoff they have said is if it's 1.75 diopters or more of cylinder, then so 10 degrees is the cutoff, and it's more than it is.
So the same issue has 2 papers, both are very interesting. The other paper is that if you have more than minus 1.5 cylinder, then you need to adjust the smile nomogram. If it is less than that, you don't need to adjust the input cylinder. So that's the other follow-up. So again, the question comes back to Contura as a platform, that do we benefit a lot by doing Contura? I don't know. The surgeons can answer.
Is there any paper comparing Contura with abrasion-free LASIK? Because this will actually, is there a paper comparing
we have it in GRS.
Abrasion-free LASIK versus Contura?
Yeah, we did one eye of abrasion-free, and Rushad is here.
Yeah.
Rushad can comment. He was the first author, and this was the first paper on the, and I think we had it in JRS.
So what was the conclusion?
To answer it, the quantity of vision, this is the paper here, the quantity of vision was the same. You probably would not get it. If you ask the patient which eye did he like, he did not really say which one he liked because both had the same thing. But if you use the quality where you went into the abrometer and those kind of things, it was statistically significant, right, Rushad? He did this work.
I think we had a difference in the spherical aberrations. It was
but the patient did not prefer one or the other.
No.
So basically for the patient it doesn't make a difference whether you do Contura or abrasion free.
So of course, but our measurement was very subjective in a room. I mean, we did not look at their night vision and other things. Like, I agree with exactly what Abhijit said. Many things what is written in the papers about night vision problems, we don't see it because we have a very small pupil. A pupil is, I think, a blessing for us.
I think we also did a similar study, 30 patients, one eye Contura, one eye wavefront optimized, and one eye smile. And what we found was that as far as spherical aberration is concerned, the induction was more with smile. As far as vertical coma, no, the other way around.
No, spherical
aberration was more with wavefront. And as far as vertical coma is concerned, it was a little more with smile.
Vertical coma again is because of centration.
3 months follow-up?
It's 3 months.
When you put on the suction, there's a tendency for the patient to roll their eyeballs up. and there's a natural Bell's phenomenon, and then you get a little bit of decentration, and this is what contributes to the coma that you see. But actually, if you are centered well, then you don't see a significant increase in the vertical coma. Vertical coma is again because of the decentration. And if you look at the spherical abrasion in our study, which was again published in the JRS many years ago, the induced spherical abrasion is much less than femtoLASIK. That is because of it is physics.
You get
There is
larger optical zones
no
with the
fluence
smile
projection losses, and you have a
and
neat
LASIK.
excision of the tissue there, and you get relatively larger optical zones with SMILE than with LASIK for this reason.
The only comparison paper of one eye SMILE versus the other eye Contura was by Canelopoulos.
Yeah,
Yes, it was.
yeah.
Yes,
We
but
have
then,
that paper? Yes.
but then that was, I mean, he just did his first 30 eyes, and the
Yeah,
laser was
this-
not optimized, no
and,
nomogram was used, there
if
was no
you-
cyclotorsion compensation.
If
So
you
need
read
to-
his conclusion, this is his conclusion. Topo-guided LASIK was superior in all visual performance parameters studied, both subjective and objective. The main difference between two techniques likely derives from the eye tracking, cyclotorsion compensation, and active control. This difference appears to affect the refractive and visual aberrations. So his results says that it is more of contrast loss, and he looked at only 3 months data, which I think. Other question I would like to ask you, because it's your.
Rohit, at 3 months, a LASIK group would, in general, not show an 86.4%.
Yeah, this is something I would like to ask you.
Even in a novice's hand, the LASIK group, even in the first month, will show better results than this. So it does
Even-
not
even
really
his
say
LASIK
much
results are not
more
as
than
good.
this.
Sorry, so what?
I think
Even
So
the LASIK results
I
are
think all
not
of us
good
should.
here.
I think all of us should note that we read only the conclusion.
Yeah, you see the LASIK results.
I-
The LASIK results themselves are not good enough.
So
So
the-
what are we talking about, a new technology here
There's,
at
there's,
end?
And
there's
if you-
two questions I'd like to ask you as editor. One, do you still accept 3 months data for publications?
So it depends. This was the first one of these comparisons, and so it had some relevance. It's slightly larger than a pilot study because it is both eyes from the same patient. It has, and again, because it is to be randomized, you can only take the authors at their word on some of these things.
So the second, I'll just complete this. The second one is the question she asked is, we don't see, at least in our published work today, you can also answer this, why is the results of LASIK only 86.4% of the patient? He says 86% of the patient and 68% of the patient developed good quality vision.
This is just not our experience.
I think here, Rohit, actually we need to ask you the question, because I think you have now kind of the nomograms and
No,
everything
but
of
I think
Contura.
anybody, Vandana, I think we all must be about 95 at least.
Even with LASIK.
Your
So
data.
I'm not sure that that's actually correct in regular clinical practices. I think under best practices, not only the surgical practice, but also the visual acuity measurements, the eye chart standardization, the standardization of technicians pushing patients a certain amount, that's probably true. Probably the lasers are performing at that level, but I'm not sure that every clinic is necessarily generating that type of outcome.
You, what about you? Because he has more nomograms than anybody, I think, on this thing. What do you think is your results roughly at 3 months? If you're doing, say, Contura, he says, John Canelopoulos says 86%. What do you think?
I think it's maybe a bit on the lower end, but you may have like.
And what is
myopic-
your thing? What is your figure?
My figure in my practice?
Yes, 3 months, yes.
I think slightly higher, but you have people who lose lines of vision for other reasons than suboptimal refractive correction, can be dry eye, can be preoperative levels of amblyopia, which are not really clearly addressed there. So it's not. I think what the message here is that in the same condition, if it was randomized, the results of the SMILE procedure are slightly lower than the LASIK for all the parameters. And I think when I watch videos about the SMILE technique, I must tell you, I don't feel comfortable because What is important in what we do as refractive surgeon is invasivity. And the paradox in the marketing is that SMILE is supposedly less invasive than LASIK. But when you look at surgery and compare them both, in LASIK, I can lift a flap in 2 or 3 movements, which maintains corneal transparency. There's only one interface there. There's no stretching. There's not a hollow volume which you induce, because in SMILE, if you remove a big lenticule, you don't sever the flap because there's no flap. So the cap has to fall on the bed underneath, and because there's no detachment, you may create microfolds like asymmetrical tissue repartition. Whereas again, to me, in LASIK, what I like is the flap, because the flap enables enhancement, and the flap is, when you repose it on the stroma, it smooths out the change in the surface that you induce with the laser ablation. And again, each spatula movement you do in the cornea may alter the corneal transparency.
Basically, your debate, your worry is more on the technique of it being more invasive for the surgeon.
What I'm saying
and
is
less invasive for the patient.
SMILE would be far superior to LASIK, far superior, if you would just do a laser and the lenticle would vanish immediately, right? Of course, but that's not the case. I mean, you have to remove that lenticle, and suppose you do an incomplete removal, what do you do after that? Suppose there's an incomplete cut, what do you do after that? I've had many colleagues in France who started with SMILE and were happy until they had that complication that I'm referring to, like incomplete, and they stopped it because they say, how can I myself have even one case like that a year in my practice? It's gonna be like a problem which will follow me after a month because the patient's gonna come back. I have a website in France which is popular, and I stopped taking questions of people who are complaining about SMILE because I would be accused to be anti-SMILE. And most questions I receive are like, had SMILE, I'm not happy. I'm not saying SMILE is bad. I'm not saying I don't do it because it's bad. I'm just saying the marketing, because you had a question, is brilliant. And again, SMILE is the best technique and think on the concept. But in practice, I think there's a big difference.
Basically, to answer this, I think he and Pavitra, both of them said, I think one of the marketing issues with this technique, which I think SMILE or Contura should adopt, is not to say that it is something which is plug and play. You know, you have money, you buy it, you play. It's not like buying a car if you know you have a driving license. They have to have certain level of training for both for Contura as well as LASIK. Otherwise, I think it will probably end up in definitely a disaster. I'm sure they're doing it, but I think they should be doing more.
I think the challenge is in 2 different aspects. In SMILE is the surgical technique, in Contura is in the acquisition of data and validation of data.
So if you really look at both the technique, one you do it with the mind, the other one you do it with your hand.
The one thing though that you just said I think is critical. Those are both true statements for experienced refractive surgeons. For inexperienced refractive surgeons, neither of these procedures are something that should be done right away. They just simply shouldn't. They are significantly more challenging than other refractive procedures. Inexperienced surgeons who should start with PRK if they're not going to have significant training, because that is the least challenging. It's still challenging, but it's the least challenging.
Idiot proof.
Especially transepithelial.
You said you wanted some anecdotal lightness.
Yes.
And training is very important. At the beginning of the last century, there was a war between Japan and Russia, and a big naval battle. And both the Russian Navy and the Japanese Navy had bought optical range-finding systems from Barr and Stroud in England. The outcome of the battle was the Japanese lost one little ship, the Russians lost almost their entire fleet. The reason? The Japanese paid to go on a training course and the Russians didn't. So training is very important.
But I think it's also important for starting PRK to be actually training yourself for that. It's not just the technique which is important, it's also the follow-up and the post-op recovery.
Was the comparison with SMILE and Contura.
Anything that you are going to do requires some amount of training, And not even PRK should be done without training.
I think I like this anecdote very well, that about the Japanese paying for the training and keeping the ship, and Russians not paying petty with that. So the issue is that today's refractive surgery is not just plug and play. I think there are a lot of changes happening. In fact, the machines are filled with a lot of, like I call it mines kind of thing. You don't know what you press and what you get. And they are all quite dangerous. And some machines have a very, very open software where you virtually, in that way, American machines are better because everything is locked.
It's got to the point where machines are becoming so complex. When the 380 jet was introduced, British Airways the story was they were going to reduce the 6 people on the cockpit to 2, a pilot and a dog. And the pilot's job was to feed the dog, and the dog's job was to bite the pilot if he tried to touch anything.
So this is an important question. I want Professor Marshall to answer this, and then Abhijit. Both of you did the initial work for biomechanics of smile. We have seen your papers. I know your slides. So do you now, in 2019, still hold the same strong values, that it is still stronger, or you change your mind?
First, I have to make a confession. I'm now doing a study for Zeiss, but on the agreement that I publish the results, whatever I found. And we've been using interferometry, and we've been measuring Zeiss smile and conventional LASIK interlace flaps, and measuring acutely, and then measuring after 3 to 6 weeks organ culture of human corneas that have undergone these 2 techniques. It's premature, but at the moment, smile is showing as slightly stronger than conventional LASIK flaps. And in each case, in order to get maximized measurements, we've done a 6 diopter correction with a specially modified machine. So there is growing evidence that smile is slightly stronger. We need to get correlation with this in the clinic, but it's not as much as I thought it was going to be, because in both cases you're cutting a large number of fibers, you're removing a relatively large amount of tissue, but that peripheral rim of intact superficial fibers in smile, other than the aperture that you're pulling the lenticle out from, does seem to confer some strength. Whether it is going to be clinically relevant at all, I don't know at this stage.
So if you just look at this paper, this was Abhijit's, this is the first paper, I think, which built the concept of smile, and Abhijit is here. And I always discuss this paper.
This is theoretical modeling.
Yes,
you
I
should
know.
say.
That's
it's
what
not real. It's theoretical modeling.
So as he said, it's correct. I mean, this is a theoretical model where we showed that if you have 2 corneas, one with smile done and one with LASIK done, smile does leave the cornea stronger compared to the LASIK eye. Now, going back to the ex vivo measurements.
In a mathematical model.
In a mathematical model. So going back to the ex vivo measurements that he has done and what even others have reported. So if you consider an ex vivo model, you do a LASIK flap and you do some tensile measurements, okay? So, and if you take a smile cornea and you just leave a, you just extract the lenticule from it and you do the measurements, obviously the LASIK will show that it is going to be weaker than the smile eye.
So
smile cornea, that's ex vivo, there is no controversy with respect to that.
So I always ask this question to all these people who use mathematics to bring this kind of a picture, is it gives you only acute response at that moment. It does not show any changes what happens. Am I right?
And yes, you're correct, and it also has one major failing. It says finite element model. It's only finite element in the XY. Currently it lacks finite elements in the Z. So it's interesting, it's helpful. I'm not sure how predictive it's going to be. And at the moment we are not getting good cross-correlation between this finite element model another finite element model that we have developed, and the real-time measurements in human tissue.
So now we have the evidence for real-time measurement to corroborate what the acute effects of the model shows.
You
so
want to talk about
this, we briefly discussed this study in the last meeting, but now we have this as a paper. So the key aspect in this paper is...
Hang on, stop right there. As Mike said, read the methods. You used a Corvus. That's not measuring biomechanics.
So we can argue on that more and more, but let's look at the data. What was this experiment? What was the study that was done
It was
here?
just not Corvus, right? You used the Corvus with the modeling also to part of it.
Well, modeling will, yeah. So in these sets of eyes, LASIK was done in one eye and SMILE was done in the other. The key aspect here is that the measurement with the Corvus was done intraoperatively when the LASIK flap was cut but not lifted. In the SMILE eye, the three-dimensional architecture of the lenticule was cut, the incision was made, but the lenticule was not extracted or separated, and we did the intraoperative measurement. And in that case, what we found is that acutely, the SMILE eye did show lesser biomechanical change than the LASIK, okay? It did show acutely. But when we repeated the measurements at 1 week and 1 month, the differences were hardly there. So I got a comment from another esteemed colleague that probably you should have done larger number of eyes to show statistically significant difference at 1 week and 1 month. I told her to do that study, I would have to do 10,000 eyes. Okay, 10,000, so 5,000 patients, because that was the sample size I needed. So at that point, clinically, I cannot be confident that this device will show the difference at long term. Acutely, we did see what we have seen ex vivo with the interferometry, that the SMILE cap was better off.
Corvus, remember, is measuring a ringing, artificially induced deflection. So what you're actually looking at there is a glorified tonometer. It's not measuring biomechanics. It gives you some elastic constant, and I'm not surprised you don't get any difference at all. You've got a change at the beginning, and then after 3 months, no change. That doesn't puzzle me at all with Corvus.
So what we are stressing on the fact here is that when you're looking for long-term changes, what comes into play is the wound healing aspect, and that is something which we cannot capture with modeling as of now. That I totally agree. But if you look at the intra, which is the blue column versus the SMILE eye, I mean, this is something that the device is picking up just intraoperatively, that once you cut the SMILE cap, once you cut the LASIK flap, there is a big difference between those two sets of eyes. But long term, the wound healing may be coming to play.
But you know, but measuring true to biomechanics, we get a slight difference.
So the slight difference.
We get a slight difference at the immediate post-operative period, but as I said at the very beginning, who knows long term?
Yeah.
So I want to ask a question to you, Professor Marshall. You worked on SMILE Extra, PRK Extra, and LASIK Extra. Based on this, SMILE Extra should do very well, because it is at the acute phase, you see very minimal changes compared to a chronic phase, compared to a LASIK, because you have a huge drop of biomechanics. So SMILE Extra, if that has to be one extra procedure where you do with cross-linking, I think that would be the best procedure would be SMILE, because there is no biomechanical loss acutely. Do you agree to this?
Yeah, absolutely. You're jumping ahead. It's some of the things we've been doing, and LASIK Extra is really very interesting, because by cross-linking the flap and the adhesion line between the two certainly conveys a significantly measurable biomechanical component. So it's going to be very interesting to see what happens with SMILE Extra. But, you know, it always confuses me when people begin to complicate. It's like combination therapy in cancer. As a scientist, I've never really come to grips with that, because if you change too many variables at the same time, it's very difficult. But yes, I agree.
No, John, we didn't get your answer. Do you think extra should be done in any of these procedures or not? Or if you want extra, which is cross-linking with the refractive procedure, if you do it based on this kind of studies, do you think the SMILE Extra should do well compared to LASIK or a PRK Extra?
I'm a great believer in cross-linking with refractive surgery, I have to confess. I published a paper with Jerry Tan looking at higher myopic correction with LASIK extra. And unbelievably, he did up to -18 with 3 years follow-up now, and they're stable. Just unbelievable. And also great results with hyperopic LASIK, which all of us know is terrible, but really good results with hyperopic LASIK extra. So yes, I agree at the moment, but I need more data to make me feel really happy. Notice I'm still wearing my presbyopic correction, and neither team has yet convinced me where I should go.
John.
Any questions on so far on this?
For John. Both the Aura and the Corvus measured deformation of the cornea. Can you comment on the relationship between deformation and actual material strength?
Yeah, the problem is that the system actually looks at ringing in the system. Many years ago, I did some experiments putting Q-switch laser shock waves in the limbus and measuring the transit time of the shock wave. And that, I thought, would give me a good measure of elastic constants of the cornea, if I knew the thickness. It was all confounded by ringing in the system. And this stimulus, I couldn't actually define what the laser impact really was. So in Corvus, you hit the front of the system and cause ringing. Corvus would be great if it could look at the effects on the cornea of cardiac cycle, which is what we've been doing with interferometry, or what some people are now beginning to do with Bruin. So it doesn't give you a clean measurement because you can't cleanly define it.
Let me rephrase it then. When you do, not you in particular, when you build anything, a building, you build in deformation. If you build something too stiff, it will break. We're looking at deformation, and at some point we're saying it's bad, when inherently it may not, up to a limit, it'll be bad. We don't know this, and I agree with you. Just all the modeling we do, mathematical modeling doesn't apply to a biological. And I would take all that modeling and the finite with a huge grain of salt.
Yeah, no, I absolutely agree. And recent studies from Abby Wilson have really confounded a lot of this biomechanical measurement, because what she's actually shown is that on accommodation, as the ciliary processes go inwards and forwards, the sclera actually comes inwards, but the cornea prelimbus goes outwards. So what we found a few years ago with cardiac cycle, the cornea is moving. I couldn't understand why, if it was moving, we didn't see a slight curvature change and a slight refractive change. Turns out that the curvature of the cornea remains constant because it's compensated by movement at the prelimbal cornea. So I agree with you, the mathematical models at the moment are not good.
And the other quick question is, on the work you're doing comparing SMILE and LASIK, I'm just curious, what thickness flaps are you doing on the LASIK?
I think 100, because that's
an
easy measurement for us.
Okay. The other question I wanted to ask you, it was a few of the people have asked, making a thinner flap or a thicker flap, does it change the biomechanics, final biomechanics at the end of the procedure? You don't need to worry about the laser. Imagine I've done a flap of 100 versus 90 versus 130. Is there a change?
It made a difference if we were, we published this some years ago with Phil Jaycock, looking at flaps at 150, 120, and I think 90. And it did make a significant difference. And that was perhaps responsible for people cutting thinner flaps, because at 150, you could lose somewhere between 25 and 30% of the corneal strength.
And I think you showed the vertical cut is more important than the transverse cut in reducing the biomechanics.
The edge cuts were the most important. So when we had the advent of Indralays and could do oblique edge cuts, That was really interesting and made it even stronger, and was one of the reasons why you shouldn't use a mechanical microkeratome.
I have a query about this Smile Extra. Most of us don't do transepithelial PRK. We take off the epithelium and do the CXL treatment. And we don't do transepithelial CXL treatment because we believe that the epithelium acts as a barrier. There's not enough oxygen reaching the cornea to create enough strengthening. And here you have a Smile, you have the full epithelium, you have a cap nearly 120 microns, which may also be a little hydrated and swollen up because of the procedure. And you're doing it under the cap. Is it really going to work? I mean, if you don't believe in transepithelial CXL, how is this going to work?
Again, we're slightly off target, but if you introduce, for example, riboflavin into the cavity.
Oxygen availability. Oxygen availability.
Oxygen, you can, one company now, Avidro, is using oxygen delivery goggles to facilitate increasing oxygen levels for enhancing. Again, I don't think there's enough data, but the scientific data looks good. Practically, I don't know.
So
yes.
Just 2 points I'd like to make about this sort of biomechanics topic. One is, I think the jury's still out on whether or not there is a difference between them. But I think the preponderance of evidence shows that if there is a difference, it's pretty small, A, and B, that is in a normal cornea. So the two things not to do are to say, I've had these patients who I have not offered LASIK to, but now I can do this miraculous procedure. First of all, because the differences, if any, are not that great. But second, again, if the breakdown in the keratoconic cornea is in the anterior most portion of the cornea, that's what you're salvaging with a Smile cap. So it could actually be worse. I hope we never see that study. But theoretically, it could be worse to do in a moderate keratoconic patient because you may be leaving the worst tissue and taking out the best that they had. The second thing, on any of the extra procedures, the number of hands that go up with, would I do a blank extra of whatever it is, versus the data to support that decision always astounds me. I would argue that the literature is exceptionally weak that extra procedures do anything positive. I would argue that it's weak that they do anything positive. Now, that doesn't mean they don't, but with literature so limited, with so many people having access to it, it concerns me that the practice has gotten way out in front of any data to support it. And while I have not surveyed people, I can't imagine very many people are offering blank extra at the same cost to the patient that they're offering blank. And that's of concern as well.
But I know there's a big differential in price of riboflavin between the rest of the world and the US, which the company claims is due to FDA costs, etc. The reason why lots of people are using it in the rest of the world is because even with the limited data, they read the data, and it's not going to cost too much, and they give the option to the patient. I agree, in the US, if you're going to have to pay £2,000 plus for the riboflavin, that's an impediment.
There are more than a few studies that show actual worse outcomes after extra procedures, at least initially. So the argument that they're benign is incorrect. The argument that they cannot induce any problem is simply incorrect. Specifically with PRK extra, where now you're doing a couple of things that could induce haze, and do you use mitomycin, do you not? There are many issues there. So I don't think you can assume they're benign, and we need more data before we say that they're really impactful.
We agree, we need more data. Regarding Smile Extra, we have been doing Smile Extra for about 6 years. And then we have 2 groups with borderline topographies moderate risk as per the Randleman score, and also bad displays which are yellow, kind of borderline. And these were like cases which you are undecided whether you can do the procedure or not. And then we have one group where we just did SMILE, and another group where we did SMILE extra. I think Sheetal can talk about the data.
Yeah, so these two groups were divided on the basis of the topography. So one was the normal topography, then the second group was abnormal topography. Of course, that was excluded.
Borderline, not
and then
abnormal, but
yeah,
borderline.
one was borderline. So we had three groups. So the borderline topography, we again had two groups in that. I mean, this was a retrospective analysis. So most of the patients, so we had patients who had undergone SMILE extra, and also who had not undergone SMILE extra, because these was earlier patients where we thought that SMILE is biomechanically better, so we did not do SMILE extra. So and groups were fairly matched in terms of the numbers.
So
and we
just
saw that
to go into that point you said earlier, we were told that it is biomechanically strong. That's what I said about. So that sometimes.
So we had ectasia. We saw ectasia in the group in which SMILE extra was not performed, but none of the eyes in which SMILE extra was done developed ectasia, and this is about 4 or 5 years data.
There's about 200 odd eyes in each
Yeah.
group, so we'll be publishing that. Because
How
it's
many ectasia?
it's 4 years, 200 odd eyes in each group.
But how many patients developed ectasia?
Ectasia, we have about six
eyes
which developed ectasia
out of 7,000 plus eyes.
Non-SMILE extra group, which
Out
had
of your abnormal
borderline
topographies.
topographies, moderate risk. Whereas the
The ones which developed
SMILE
ectasia
extra-
were all abnormal, as in the borderline topographies, not abnormal.
But they did not
7 out
have
of
extra.
200.
They did not have
The
extra.
same type of abnormal topographies you did extra on
had
them,
extra, did
and
not
they did not develop a topography in the same duration of time.
About
Yeah.
4 years follow-up.
About
So
4 years follow-up.
So that's 6 out of 7,000, and this is slightly off topic.